Good afternoon, everyone. Thanks for joining today's overview of the 2024 proposed rule for the Quality Payment Program. During today's webinar, subject matter experts from CMS will provide an overview and future direction of the Quality Payment Program, explain 2024 proposed policy changes for traditional MIPS, MIPS Value Pathways, the Medicare Shared Savings Program, and advanced APMs, and highlight key differences between the 2023 performance year requirements and requirements proposed for the 2024 performance year. Following the presentation, CMS will answer questions from attendees as time permits. And I do just want to point out that a recording of today's webinar, as well as a copy of the slides, which will include all the hyperlinks you see on screen today, will be available on the QPP webinar library in the coming weeks. But with that said, I will now turn it over to Dr. Ron Klein to get us started. Dr. Klein?
All right, let's try that again. The host muted me, so I unmuted myself. You guys can all hear me okay, hopefully?
Yep.
Good,
Yeah.
Thank you. All right, good afternoon, everyone. Thank you for joining today's webinar. My name is Ron Klein. I'm the Chief Medical Officer for the Quality Measurement and Value-Based Incentives Group within CMS's Center for Clinical Standards and Quality. Today, we'll be discussing the proposed Quality Payment Program policy updates in the 2024 Medicare Physician Fee Schedule Notice of Proposed Rulemaking, which was released on July 13th of this year. In this proposed rule, we've included proposed policies for the QPP program that first continue the development and maintenance of MVPs, or merit-based incentive payment system value pathways, to support the use of digital measurement and health information technology, as well as the integrity of program data, and finally, increase the potential return on investment for MIPS participation. We are proposing 5 new MVPs to be available for the 2024 performance year, along with revisions to all previously finalized MVPs. We are also streamlining and strengthening our inventory of MIPS promoting interoperability, quality, and cost measures, as well as improvement activities. For advanced APMs, we're proposing to create Medicare CQMs as a new collection type for Shared Savings Program ACOs under the APM Performance Pathways program. We're proposing to require all MIPS eligible clinicians, qualifying APM participants, also known as QPs, and partial QPs participating in Shared Savings Program ACO to report on MIPS promoting interoperability performance category measures. We're proposing to remove the 75% certified EHR technology requirements for all advanced APMs and instead require each advanced APM to use CERT. These are just some of the policies we're proposing to improve quality and value, reduce burden, and increase health equity. My colleagues will discuss these and other proposals in more detail over the course of the webinar. We've also issued several RFIs to gather feedback on the future of the Quality Payment Program, specifically the future of MVPs, the alignment across QPP and the Medicare Shared Savings Program, and recommendations on publicly displaying data on our Care Compare website. We value your feedback and hope you will provide response to these RFIs, as well as the proposed policies. Comments are due by 5 p.m. on September 11th, 2023. We're looking forward to hearing from you. In closing, I'd like to commend the dedication, flexibility, and excellent care that clinicians have provided to patients throughout the COVID-19 pandemic. As we begin to transition away from the public health emergency response, we look forward to getting the Quality Payment Program back on track and focusing on the path ahead. Now, without further delay, I will turn it over to Renee O'Neill, QPP Engagement Team Lead, to provide more details about today's webinar.
Thank you, Dr. Klein. Next slide, please. Okay, I'll just go over our agenda for today. We'll be going over like Dr. Klein said, the 2024 NPRM proposed rule updates for QPP, including for MIPS, MVPs, APMs, Medicare Shared Savings Program ACOs, and public reporting policies. We will then provide you with information about help and support and include a Q&A session time as allotted. Next slide. As you are by now aware, on July 13th, CMS issued the proposed policy for QPP via the 2024 calendar year PFS. Comments are due, like Dr. Klein stated, September 11th. Please refer to the proposed rule for detailed instructions on how to submit comments. This means that you must submit comments in one of the following ways listed below here on this slide, using the file code CMS-1784-P by via electronically through regulations.gov, by regular mail, or by express or overnight mail. Next slide. Okay, for future directions, as we transition away from the COVID-19 emergency response, we continue to focus on moving QPP forward. To further these goals, the proposed rule focuses on continuing to develop and maintain NVPs, support the use of digital measures and health information technology, and the integrity of program data, as well as increase the potential return on investment for MIPS participation. Next slide. Our key QPP proposed policies include introducing 5 new MVPs to include updates to all current MVPs, eliminate the IT vendor category, update the MIPS inventory, and continuing the automatic reweighing of the MIPS promoting interoperability performance category for clinical social workers. Next slide. The proposed changes to MIPS scoring methodology, data completeness, and performance thresholds include using an average of the mean final score from the 2017 through the 2019 performance years in order to establish the performance threshold for the 2024 performance year at 82 points. As well as maintaining the data completeness threshold for the quality performance category at 75% for the 2026 performance year, and incrementally increasing the data completeness threshold for the quality performance category to 80% in the 2027 performance year. Updating the cost improvement scoring methodology to account for improvement at the performance category level rather than measure level, beginning in the 2023 performance year. Increase the performance period for the MIPS promoting interoperability performance category from 90 to 180 continuous days within the calendar year. Next slide. In addition, we're proposing to establishing the CQM and ACOs participating in the Shared Savings Program as a new collection type for Shared Savings Program ACOs under the APP. Medicare CQMs would serve as a transition collection type to help some ACOs build the infrastructure, skills, knowledge, and expertise necessary to report the all payer, all patient MIPS CQMs and ECQMs by defining a population of beneficiaries that exists within all payer, all patient MIPS CQM specifications, and the population to claims encounters with ACO professionals with specialties used in assignment. Removing the CERT with threshold requirements and requiring reporting of the MIPS reporting interoperability performance category for all tracks in the Shared Savings Program. Modifying the definition of CERT and ending the current 75% CERT use requirement. Next slide. We are also soliciting comments on scoring incentives that would be applied to an ACO's health equity adjusted quality performance score. This is to use to calculate share savings and share losses under the Shared Savings Program when specialists who participate in the ACO report quality quality MVPs. Next slide. Can you go back one slide, please? We have also proposed to modify existing policies about publicly reporting procedure utilization data and signaled our intent to begin publicly reporting cost measures beginning with the 2024 performance year. We have included an RFI seeking comments on potential approaches to and considerations for this public reporting. Next slide. And here in the slide, you will find a list of the available resources published in the QPP site for your reference. Now I will turn the presentation over to Sophia, who will go into further detail about the MIPS, about the MVP's proposed policies. Thank you.
Thanks, Renee. Next slide, please. All right, one more slide over, slide 12. Thank you. So to get us started today, we just wanted to provide a recap. This is something that we've previously finalized on what the definition of an MVP participant is. So an MVP participant is a broader term that encompasses an individual clinician, a single specialty group, a multi-specialty group, a subgroup, or an APM entity. And so sometimes we have policies that apply to all of these clinician types, and that's when we use the term MVP participant to broadly refer to all of these cohorts. In addition to this policy that was previously finalized, we also previously finalized that we would use the Medicare Part B claims data as the source when determining a specialty type. And the only reason why we've called this out in policy is because we wanted to distinguish a single specialty group and define that. And so we did previously finalize the definition of a single specialty group to be a group that consists of one specialty type as determined by the Medicare Part B claims data source. A multi-specialty group, on the other hand, consists of two or more specialty types as determined by the Part B claims data. And so really these distinguishments are important because when we talk about multi-specialty groups, we've also previously finalized in in the previous rulemaking cycles in 2022, we previously finalized that multi-specialty groups would be required to form subgroups starting with calendar year 2026 in order to report MIPS Value Pathways. And so that's why those terms have been further defined in the past. Next slide, please. As Renee has mentioned, we are proposing updates to our MIPS Value Pathway inventory, and that includes making maintenance updates to our existing inventory of 12 MVPs. And there you see the 10 listed here. We are making updates to add and possibly remove improvement activities and or measures. And we are also proposing 5 new MVPs around women's health, ear, nose, and throat disorders, infectious disease, including hepatitis C and HIV, mental health and substance use disorders, and rehab support for musculoskeletal care. And that is intended to be developed around the therapists that are involved in support of that care. Next slide, please. And so, sorry, one last thing I forgot to mention on the last slide that was included as a maintenance update is that we are proposing to include in all our MVPs the availability of the social determinants of health quality measure. And that was one overall update that we chose to move forward with as a proposal. So in addition to our maintenance updates, we are proposing through our MVP maintenance process to consolidate 2 of our primary care MVPs into 1. And the consolidation is being done with the intention to also align with our Universal Foundation of Quality Measures in discussion with our quality working group and our colleagues across the centers. So the value in primary care MVP has been proposed, and this is done to really create some alignment across some of the initiatives that are going on in CMS, and to also promote certain clinical concepts that we feel are important to highlight within primary care. Next slide, please. With regards to the subgroup policies, we proposed that subgroups would not be eligible to receive facility-based scoring at the subgroup level. Subgroups would be eligible to also request targeted review of their MIPS payment adjustments factor associated with MVP reporting. So the contingency there is that you actually submit data at the subgroup level in order to submit a targeted review at the subgroup level. Subgroups would only receive reweighting through their affiliated group and not through the EUC exception application independent of their affiliated group. So the underlying note here is that if a group submits an EUC application, then the results of that EUC group should apply to the subgroup as well. If there was an issue that came up in the subgroup, it likely impacted the group. So therefore, we felt that changing this so that the reweighting occurred at the group level and trickled down to the subgroup made sense. In addition to that, with regards to subgroups and the complex patient bonus, we propose that subgroups receive the complex patient bonus for their based off their affiliated group, beginning with the 2024 performance year. Next slide, please. Okay, and I will turn it over to Julie Johnson for the next section. Julie, if you're speaking, you're on mute.
Oh, thank you, Sophia. I was. For this next section, we will give a brief overview of QPP and MIPS before we provide more details on the proposed policies for the 2024 performance period. Next slide, please. The Medicare Access and CHIP Reauthorization Act of 2015, or MACRA, ended the use of the Sustainable Growth Rate formula, which would have resulted in a significant cut to Medicare payment rates to clinicians. MACRA now advances a forward-looking coordinated framework for clinicians to participate called the Quality Payment Program, or QPP. Under the QPP, CMS incentivizes clinicians providing care to Medicare beneficiaries to improve the quality and safety of care to all individuals and aims to reduce the administrative burden on clinicians, allowing more time to focus on person-centered care and improving health outcomes. The QPP is comprised of 2 tracks: the Merit-Based Incentive Payment System, or MIPS, and Advanced Alternative Payment Models, or APMs. In MIPS, clinicians may earn performance-based payment adjustments based on the services provided to Medicare patients. An advanced APM is a customized payment approach designed to provide incentives to clinicians who are providing high-quality, high-value care and can focus on specific clinical conditions, care episodes, or populations. Next slide, please. We want to highlight that while the QPP consists of 2 tracks, MIPS and advanced APMs, these tracks can overlap. Until MIPS eligible clinicians earn qualifying APM participant or QP status, partial QP status, or are otherwise exempt, these clinicians are required to participate in MIPS even if they are part of a group or other entity that's participating in an advanced APM. Next slide, please. So what does it mean to be a qualifying APM participant for 2024? Generally, a qualifying APM participant, or QP, is an eligible clinician who has met or exceeded the payment amount or patient count thresholds based on participation requirements for advanced APMs. Partial QPs are those clinicians who are very close to meeting the payment amount or patient count thresholds of advanced APM participation requirements, and therefore can choose whether or not to participate in MIPS. As I just mentioned, unless MIPS eligible clinicians have received QP status, partial QP status, or are otherwise exempt, these clinicians are required to participate in MIPS even if they are part of an advanced APM. Next slide, please. As mentioned previously, MIPS is one of the primary ways to participate in QPP. For clinicians participating in MIPS, CMS evaluates performance across 4 categories: quality, cost, improvement activities, and promoting interoperability. These performance categories have different weights, and the scores from each of the categories are added together for a MIPS final score. This final score is compared to the MIPS performance threshold to determine if clinicians receive a positive, negative, or neutral payment adjustment. For the 2024 performance period, the performance categories are weighted the same as 2023, 30% for both quality and cost, 15% for improvement activities, and 25% for promoting interoperability. Note that we are statutorily required to weight cost and quality equally, which began with the 2022 performance year. Next slide, please. For 2024, the standard weighting for small practices has not changed. You'll see here that the promoting interoperability performance category is automatically reweighted across the quality improvement activities performance categories, and cost remains at the same weight. When both the cost and promoting interoperability categories are reweighted, 50% of the final score will come from quality and 50% will come from improvement activities. Next slide, please. There are no changes proposed to these weighting policies for 2024. Currently, MIPS eligible clinicians that participate in traditional MIPS as an APM entity have different performance category weights than clinicians who participate in traditional MIPS as an individual, group, or virtual group. The APM performance pathway, or APP, also has different scoring weights compared to APM entities participating in traditional MIPS. When an APM entity reports traditional MIPS or an MVP, CMS will reweight the quality performance category to 55% according to traditional MIPS performance category reweighting rules, as opposed to 50% under the APP. Now I will turn it back over to Sophia to go over the proposed changes to third-party intermediaries during the 2024 performance period.
Thanks, Julie. Next slide, please. Okay, so for the third-party intermediaries, one of the big key items that Renee had flagged earlier is we are proposing to remove the health IT intermediary from our third-party intermediary category, and that is beginning with the calendar year 2025 performance period. So it would be implemented with a delayed implementation. So with that being said, a health IT vendor that would like to participate and support the data submission in the MIPS program could do so by self-nominating as a QCDR or a qualified registry and submitting data on clinicians' behalf. In addition to that update, we've also proposed a number of changes to the self-nomination and approval process. This is specifically for our QCDRs, our qualified clinical data registries, and qualified registries. So one of the updates is that we are updating the requirements to require that the QCDRs and registries include the MVP titles and measure and activity identifiers for the IA and PI measures within their self-nomination. In addition to that, specifying the requirements for a simplified self-nom form for existing QCDRs and qualified registries in good standing, so providing additional requirements there. In addition to those two items, we have proposed to add measures submitted after self-nomination as a reason as to why we would reject a QCDR measure. In the past, we've had QCDRs try to submit measures past the deadline for CMS consideration. So to make it abundantly clear that we will not accept QCDR measure submissions for our consideration past the deadline, we've proposed to add this as a criteria. In addition to that one, we are also proposing to implement a requirement that the QCDRs publicly post their approved QCDR measure specifications throughout the duration of the performance year and associated submission period. We've had issues with vendors either having the wrong version of their QCDR measures posted or taking it down mid-year, and thereby causing some level of confusion with their clients. We want to ensure consistency with what we CMS has approved versus what you as a QCDR post. And so therefore we are proposing to make that a requirement. Next slide, please. With continuation of the self-nomination requirements, we are proposing to specify the required sampling methodology for data validation audits. Proposing to also require that the QCDRs and registries attest to the accuracy of their information and their qualified postings. And also requiring them to attest that they can provide CMS with access to review the data upon request. In addition to those self-nomination specific requirements, we also are providing some level of clarity with regards to our expectations of QCDRs and registries supporting MIPS Value Pathways. We want to clarify through this proposal that a QCDR or registry must support all measures and improvement activities within an MVP, with the two exceptions, one of which is that if an MVP includes several specialties, because there may be a likelihood that an MVP is constructed in a manner that includes multiple specialties, then the QCDR qualified registry is only expected to support the measures that are pertinent to the specialty of their clinician. So for example, if you are a surgery specific QCDR, and you only support your clients are only surgeons, we wouldn't expect that you support any anesthesia measures or physical therapy measures. As an example, we wouldn't want you to have to support measures that are not clinically relevant to the specialist that you support. So we wanted to provide that clarity through that proposal. In addition to that, the other aspect of it is specific to the QCDR measures and the QCDRs that can report them. QCDR measures are only required to be supported by the QCDR measure owner. And in the instances where a QCDR does not own the QCDR measures found within the MVP, the QCDR can only support those measures. Another QCDR can only support those measures if they have the appropriate permission. So it's an existing process that QCDRs have to seek each other's permission to report or support the reporting of a given QCDR measure. So the QCDR borrower must seek that permission, and that still holds true within the realm of MVP reporting. It is, however, not a requirement that QCDR borrowers do this. It's to their discretion. Next slide, please. And this last item is, these last items are related to the remedial action and termination policies that go across all of our third-party intermediaries. We are proposing that we could take remedial action, including termination, for third-party intermediaries that fail to maintain up-to-date contact information. It's very important that we are able to contact you when issues occur or when we need to gather some information, and we've had difficulties in the past. So we want to make sure that's clear, the expectation. We would also require that third-party intermediaries notify us when a corrective action plan has been successfully completed. Therefore, we can see that action's been taken, and we can see the end result to ensure that corrective action has been implemented, and that hopefully there will be fewer to no issues in the future. And the last item is we could initiate termination of a third-party intermediary that has been on remedial action for 2 consecutive years. So if we have not seen year-over-year improvement, the ability to successfully implement a corrective action plan that we can terminate a third-party intermediary. Next slide, please. And for this section, I will turn it over to my colleague, Lisa Marie Gomez. Thank you.
Thanks, Sophia. I am going to discuss our proposed policies with regard to the quality performance category. Next slide, please. So now I'm going to discuss our quality measures. So we are proposing proposing an inventory for MIPS quality measures. So on an annual basis, we review measures to determine if measures, for example, are topped out or extremely topped out. And if they are, we would propose measures be removed. So as I indicated, we reviewed our inventory to determine which measures will need to be removed. We also as part of our review process, review measures that could potentially be implemented in MIPS. So as a result of those two processes, we are proposing the addition of 14 MIPS quality measures, including 1 new composite measure and 7 high priority measures, 1 of which 4 are patient-reported outcome measures. We're proposing substantive changes to 59 existing quality measures. We're also proposing removal of 3 quality measures, partially removal of 3 quality measures from the MIPS quality measure inventory. So what that means in terms of partial removal means that we're proposing to remove measures from traditional MIPS, but proposing to retain them for an MVP or for use in an MVP. We're also proposing the removal of 12 quality measures. I just want to note that for the 2024 performance year, we are proposing a total of 200 MIPS quality measures. So that would be in our inventory for 2024. I want to note that QCR measures, they are not included in the above measure inventory. QCR measures go through a different process outside of the process that I just outlined in terms of adding measures or removing measures in the MIPS quality inventory. Next slide, please. Now I'm going to discuss our proposals with regard to data completeness thresholds. Before I get into our proposals, I just want to note that for the 2026 performance year, we have previously established a data completeness threshold of 75%. So again, this was previously finalized. And so for the 2026 performance period, 75%. We previously finalized the policies for the 2024 and 2025 performance years. So given that we have established, previous policies for 2026, we are proposing a data completeness threshold of 75%, which would be consistent with what we had previously finalized with the 2024 and 2025 performance years. We're also proposing a data completeness threshold of 80% for the 2027 performance year. We're also proposing to establish data completeness thresholds for Medicare CQMs. As you will hear later on in the presentation, Medicare CQMs is a new collection type, specifically under the Shared Savings Program, specifically for ACOs reporting under the APP. And again, that more information about the Medicare CQM will be discussed later on in the presentation. So for the data completeness threshold for the Medicare CQM, we are proposing a data completeness threshold of 75% for the 2024, 2025, and 2026 performance years. For the 2027 performance year, we're proposing a data completeness threshold of 80%. I just want to highlight with regard to the web interface. So the web interface is no longer available to groups and virtual groups participating or reporting through MIPS, but it is available for Shared Savings Program ACOs participating under the APP. So for the 2023 performance period and also for 2024, the web interface is available, and the data completeness for the web interface relates to a different requirement. So you report on the first 248 consecutively ranked Medicare patients in a sample for a measure, or all patients if a sample has less than 248 patients. Next slide, please. And I'm going to discuss our proposal with regard to our policy with regard to ICD-10 coding updates. So we're proposing to modify our criteria for assessing ICD-10 coding updates. So we are proposing to eliminate the automatic 10% threshold of coding changes that would trigger measure suppression or truncation. And instead, we are proposing to review ICD-10 coding updates on a case-by-case basis. We're also proposing to assess each collection type of a given measure separately to determine if a measure's collection type would be truncated, suppressed, or would continue to be reported for a 12-month performance period. Next slide, please. I'm going to discuss a proposal with regards to the Capture MIPS survey, which relates to vendors. We're proposing to require groups, virtual groups, subgroups, and APM entities, including Shared Savings Program ACOs reporting under the APP, to contract with a Capture MIPS survey vendor to administer the Spanish survey translation to Spanish-preferring patients using the procedures detailed in the Capture MIPS Quality Assurance Guidelines. So prior to this proposal, English was the only translation required for the Capture MIPS survey, and now we are proposing to now not only require English, but also we're proposing to require the Spanish translation. We're also encouraging groups, virtual groups, subgroups, and APM entities, including Shared Savings Program, ACOs reporting on the APP, to administer the Capture MIPS survey and other available translations, which include Cantonese, Korean, Mandarin, Portuguese, Russian, and Vietnamese. Next slide, please. Now I'm going to turn the presentation over to my colleague Ray to go over the proposed policies relating to the cost performance category.
Thank you, Lisa Marie. Hi, everyone. My name is Ray Desautel, and I'm the cost measures SME for the MIPS program. Next slide, please. Okay, so for cost measures, we are proposing to add 5 new episode-based cost measures and also proposing to remove 1 episode-based cost measure. The 5 measures we are proposing are psychoses and related conditions, depression, heart failure, low back pain, and emergency medicine. And then we are proposing to remove the simple pneumonia and hospitalization cost measure. Next slide, please. And so we are also proposing to update the care episode and patient conditions groups and codes list. We're proposing to add emergency medicine and psychoses and related conditions as care episode groups. And then we're also proposing to add depression, heart failure, and low back pain as patient condition groups. And finally, we're looking to remove simple pneumonia and hospitalization from the care episode and patient condition codes and groups list. And if finalized, that would leave a total of 29 cost measures available for the 2024 performance period. And that's all I had for cost measures, but I'll now pass it to my colleague Christina for cost scoring.
Thanks, Ray. Next slide, please. Hello, my name is Christina Robertson, and I'll go over the cost scoring part of our proposed policy for 2024. So in our starting in performance year 2024, starting in performance year 2023, we're proposing to revise the cost improvement scoring methodology, which includes measuring improvement at the category level. So it's a change from the current policy that is at the measure level. And from a scoring perspective, we are proposing that the maximum cost improvement score of 1 percentage point out of 100 percentage point be available. And we're also proposing that the maximum cost improvement score be 0 percentage points for the 2022 performance year. And I will pass it on to my colleague Vidya to talk about the improvement activities.
Thanks, Christina. My name is Vidya Selipin, and I will be reviewing the traditional MIPS improvement activities or IA proposals. Next slide, please. For the calendar year 2024 improvement activities performance category, we've proposed changes to our inventory as follows. We are proposing to add 5 new activities, modify 1 existing activity, and remove 3 existing activities. Of the 5 new activities that we are proposing, 1 is an MVP specific activity entitled Practice-Wide Quality Improvement in MIPS Value Pathways. 2 of the new improvement activities that we are proposing are in the population management subcategory, and they are entitled Improving Practice Capacity for HIV Prevention Services and Use of Computable Guidelines and Clinical Decision Support to Improve Adherence for Cervical Cancer Screening and Management Guidelines. The remaining 2 new activities that we are proposing are in the behavioral health subcategory, and they are entitled Behavioral Mental Health and Substance Use Screening and Referral for Pregnant and Postpartum Women, and Behavioral Mental Health and Substance Use Screening and Referral for older adults. We are proposing to make a change to 1 current activity, and that is PSPA 16, which is use decision support and standardized treatment protocols to manage workflow in the team to meet patient needs. We are proposing to revise the activity to promote the use of clinical decision support and particularly open source, freely available, interoperable CDS. We are also proposing to remove 3 existing improvement activities. The first that we are proposing to remove is BMH 6, which is implementation of co-location PCP and MH services. We note that this IA overlaps with BMH 7, which is implementation of integrated patient-centered behavioral health model, which we feel better aligns with the evidence supporting improved patient outcomes. The second activity that we're proposing to remove is BMH 13, which is obtain or renew an approved waiver for provision of buprenorphine as medication-assisted treatment for opioid use disorder. In late December 2022, the end of the X waiver was announced, and so clinicians no longer need to complete training and obtain a waiver from the DEA to be able to prescribe it. Please note that the activity has also been suspended from the program for calendar year 2023, and so may not be completed or attested to. It's no longer available. The third activity that we propose to remove is PSPA 29, consulting appropriate use criteria using clinical decision support when ordering advanced diagnostic imaging. We are proposing to remove this activity as this program has ended, so this activity is obsolete and no longer available for completion. All of these proposals can be reviewed in further detail in Appendix 2 in tables A, B, and C of the proposed rule. I will now pass the presentation on to Elizabeth Holland to review the PI proposals.
Thank you, Vidya. My name is Elizabeth Holland, and I will be talking about the promoting interoperability performance category. Next slide, please. Okay, to start, we did propose to continue the automatic reweighting for clinical social workers for the 2024 performance year. You will note that we did not propose to continue the automatic reweighting for any of these other clinician types listed in column 2. Thus, these clinicians will be required to report for the promoting interoperability performance category unless they qualify for reweighting due to a special status. And by that, we mean something like they're in a small practice or they're hospital based, or if they applied for and were approved for a MIPS promoting interoperability hardship exception. I do note that if the clinical social workers or one of the special statuses or the hardships are reweighted, those 25 points that are allocated to the promoting interoperability performance category will be redistributed to another performance category. Next slide, please. Okay, another change is the performance period. Since the beginning of MIPS, the performance period for the promoting interoperability performance category has been 90 days. Starting in 2024, we're proposing to increase the length of the reporting period to a minimum of 180 days. And this is actually in alignment with our promoting interoperability program for eligible hospitals and critical access hospitals. Next slide, please. Next, we're proposing to revise the definition of certified electronic health technology. So we will no longer be specifying an edition, like now we're using the 21st Century Cures Update edition, but we will be removing the edition, and instead we will be relying on the certification criteria that are maintained at volume 45 of the Code of Federal Regulations. Next slide, please. For the query a prescription drug monitoring program measure, you may recall that last year we made it a required measure. We realized there were some issues with the exclusion that we established last year, so we are proposing to fix this by making the exclusion more specific. So it would be, does not electronically prescribe any Schedule II opioid or Schedule 3 or 4 drugs during the performance period. And you may recall that for this measure, the requirement is for clinicians to query a PDP one time during their performance period to fulfill the measure. Next slide, please. Lastly, we've had the safety assurance factors for EHR resilience or SAFER guide measure. It's to review the high priority practices safer guide. This has been a measure for which you could submit a yes or a no, and that would fulfill the measure. If you leave it blank, you will fail promoting interoperability and earn a score of 0. But previously, both a yes or a no would fulfill it. What the proposal is starting in 2024 is that we would require that you give us a yes response, that you have reviewed the high priority practices safer guide. Next slide. I'm now turning it back over to Christina, I believe.
Thanks, Elizabeth. So over the next section, I will be discussing the final scoring proposed policy for quality and cost. Next slide, please. So for 2024 MIPS, our proposed policies is that for no changes to the performance category weights for the traditional MIPS and APPs, and I'll go over traditional MIPS first and the MVPs. So this means that the final scoring for quality performance category will remain at 30%. The cost performance category weight will remain at 30%, and the improvement activity performance category will remain at 15%. And last but not least, for promoting interoperability, excuse me, I have a difficulty saying that word, performance category will remain at 25%. And similarly, for are no changes for APPs, so quality will stay at 50%, cost will stay at 0%, the improvement activities will stay at 20%, and again, last but not least, PI will stay at 30%. And I will pass it back to Sophia to cover payment adjustments.
Thank you so much, Christina. Next slide, please. Great, thank you. So just as a reminder, the 2022 performance year was the final year for the additional performance threshold and the additional MIPS payment adjustment for exceptional performance. And as another reminder, the max negative payment adjustment for the 2022 payment year and beyond remains at -9%. You'll note here that the thresholds here for final scores for 2023, you would need to achieve 75 points to obtain a neutral payment adjustment. Anything above that would then put you in the positive adjustments zone. Anything below the 75 points, which is 74.99 and below, would then take you into the negative category where you possibly can achieve between 0 and -9%. Next slide, please. For the performance threshold specifically, we've set the performance threshold and had it at 75 for a number of years, particularly during the public health emergency. Through this proposed rule for calendar year 2024, we are proposing to do 2 things. One of which is to change the methodology that in which we determine what the performance threshold should be. We are proposing to take the mean of the final scores for multiple years rather than just the past year. And this would be what we're proposing is to leverage the mean final score for all MIPS eligible clinicians for the past performance periods of 2017 through 2019 in order to establish the 2024 performance year performance threshold. And the performance threshold value that we have proposed is 82. And that is the proposal that we are looking to move forward with. Next slide, please. Okay, and for this next slide, I'm going to turn it over to my colleague, Yona. Thank you.
Hey, thank you, Sophia. Okay, so with regards to our proposal related to the targeted review process, we're proposing to open the targeted review submission period when we release the MIPS final scores and then keep it open for 30 days after the payment adjustments are released. This would then maintain that approximately 60-day period for requesting a targeted review, with around 30 days taking place before the payment adjustments are released and continuing for 30 days after the payment adjustments are released. In addition, we're proposing that in the event that CMS requests additional information related to a submission, it should be provided within 15 days of receipt of that request. And with that, I will turn it now over to Richard Jensen, who will cover advanced APM proposed policies.
Thank you, Yana. Next slide. So we have a few things here to remind you about that are already in place because Congress had adjusted them in the last year. Just a reminder that Congress did not extend the APM incentive payment beyond the 2023 performance year. Instead, beginning in 2024 performance year, Congress provided that QPs will receive a higher Medicare PFS update, known as the qualifying APM conversion factor, of 0.75% compared to non-QPs who will receive a 0.25% Medicare PFS update. QPs will continue to be excluded from MIPS reporting and payment adjustments for the applicable year. Next slide. Also regarding QP and partial QP thresholds, by way of the Consolidated Appropriation Act 2023, Congress froze the QP and partial QP thresholds under both the payment and patient count methods for the Medicare option and the all-payer combination option for 2023 performance year. The threshold values for 2024 performance year will increase unless there is additional congressional intervention. And specifically, Medicare payments, the QP threshold will increase from 50% to 75%. For partial QP, thresholds will increase from 40% to 50%. And then for under the Medicare patient count, QP threshold will increase from 35% to 50%, and partial QPs thresholds will increase from 25 to 35%. Next slide. One of the things we're proposing in this year's rule is that QP determinations will be done at the individual level. We're called the IQP, instead of at the APM entity level as we have been calculating them. To complement the move to IQP-based determination, CMS will also propose to change the definition of attribution eligible beneficiary. And the sixth criterion will no longer be limited to EM services. Beneficiaries attributed to an APM entity and receiving covered professional services from an eligible clinician on the participation list would count as an attribution beneficiary, even if such beneficiaries have not received any of the EM services that are currently used for attribution. Next slide. Regarding CERT, we're updating the definition of CERT for purposes of Medicare and other payer advanced APM determinations. And we're removing the 75% threshold for CERT use to specify that the advanced APM require the use of CERT among its participants. To be an advanced APM, the APM must require the use of certified EHR technology, which means EHR technology certified under ONC Health IT certification program that meets first, the 2015 edition-based EHR definition or any subsequent based EHR definition is promulgated as defined in 45 CFR 170.102 and any such ONC Health IT certification criteria adoption or updated in 45 CFR that are determined applicable for the APM for the year. Consideration factors such as clinical practice area, promotion of interoperability, relevance to reporting on applicable quality measures, clinical care delivery objectives of the APM, or any other factor relevant to the documentation of the clinical care to patients or their healthcare providers in the APM. And I will now pass it off to change the slide. I'm not sure who's next. I'm sorry.
Hi, this is Sabrina Ahmed, and I'll be reviewing the Shared Savings Program quality proposals. Next slide, please. As mentioned earlier in this presentation, for performance year 2024 and subsequent performance years, we're proposing to establish Medicare CQMs as a new collection type for Shared Savings Program ACOs under the APP. The Medicare CQMs would serve as a transition collection type to help ACOs build the infrastructure, skills, knowledge, and expertise necessary to report the all-payer outpatient Medicare CQMs and ECQMs. Medicare CQM is a MIPS CQM reported by an ACO on only the ACO's Medicare fee-for-service beneficiaries who had a visit with the clinician specialty used in assigning beneficiaries to the ACO during the quality measurement period, or who has designated an ACO professional participating in the ACO as responsible for coordinating their overall care. In order to aid ACOs in the process of patient matching and data aggregation necessary to report Medicare CQMs, upon the ACO's request, we would provide ACOs with a list of beneficiaries who are eligible for Medicare CQMs within the ACO on an annual basis at the beginning of the quality data submission period. Since we would not have full runout on performance year claims data prior to the start of the quality data submission period, the list of beneficiaries eligible for Medicare CQMs would not be a complete list of beneficiaries who should be included in an ACO's Medicare CQM reporting. Therefore, ACOs would have to ensure that all beneficiaries who meet both the Medicare CQM specification and are eligible for Medicare CQM reporting are included in the ACO's eligible population for reporting each Medicare CQM. We're also proposing to use the MIPS data completeness criteria thresholds as described in slide 28 for Medicare CQMs, establishing data completeness at 75% for performance years 2024, 2025, and 2026, and at 80% for performance year 2027. We're proposing that benchmarks for scoring ACOs on the Medicare CQMs under MIPS would be developed in alignment with MIPS benchmarking policies. We're also proposing that ACOs that report Medicare CQMs would be eligible for the health equity adjustment to their quality performance category score when we calculate their shared savings payments. Next slide, please. Currently, the shared savings program and MIPS differ in their cert requirements. So in order to align the shared savings program with MIPS, we're proposing to sunset the shared savings program cert threshold requirements beginning performance year 2024 and adding a new requirement for performance years beginning on or after January 1, 2024, that all MIPS eligible clinicians, QPs, and partial QPs participating in the ACO, regardless of track, and unless otherwise excluded, are to report the MIPS promoting interoperability, performance category measures, and requirements to MIPS at the individual, group, virtual group, or APM entity level, and earn a MIPS performance category score for the MIPS promoting interoperability performance category. Next slide, please. This slide covers two major proposals for revising the quality performance standard under the shared savings program. For performance year 2024 and subsequent performance years, we're proposing to use historical submission level MIPS quality performance category scores to calculate the 40th percentile MIPS quality performance category score. This approach would allow CMS to provide ACOs with the shared savings program quality performance standard they must meet in order to share in savings at the maximum sharing rate prior to the start of the performance period. The second proposal is related to applying a shared savings program scoring policy for excluded APP measures. Given that ACOs do not have a choice of measures they can report under the APP, we do not want to adversely impact shared savings determinations for events outside the ACO's control, such as when a measure is excluded. Therefore, we're proposing that for performance year 2024 and subsequent performance years, if an ACO reports all required measures under the APP and meets the data completeness requirement for all the required measures and receives a MIPS quality performance category score, and additionally, the ACO's total available measure achievement points used to calculate the ACO's quality performance category score for the performance year is reduced due to measure exclusion, then we would use the higher of the ACO's health equity adjusted quality performance score or the equivalent of the 40th percentile
MIPS quality performance category score to determine whether the ACO meets the quality performance standard required to share in savings at the maximum rate under its track. Next slide, please. So we have an RFI on MVP reporting for specialists. In Shared Savings Program ACOs, we're soliciting comments on scoring incentives that would be applied to an ACO's health equity adjusted quality performance score used to calculate shared savings and shared losses under the Shared Savings Program when specialists who participate in the ACO report MVPs. So this is the end of the Shared Savings Program part of the presentation. Additional Shared Savings Program proposals are described in the fact sheet that's linked on slide 10. Next, I would like to hand the presentation off to Julie Johnson. Thank you.
Thank you. Hello again. Now we'll go over a few proposed changes for public reporting in 2024. Next slide, please. In 2023, when we finalized publishing an indicator for clinicians providing telehealth services on the compare tool of Medicare.gov, we identified these clinicians using the codes POS02 and POS10, as well as the modifier 95. We are proposing to modify the existing policy to identify clinicians using the most recent codes at the time data is refreshed to reduce annual regulatory burden and to avoid inaccuracies due to coding updates occurring outside of the physician fee schedule rulemaking cycle. Next slide, please. CMS is also proposing to modify existing policies around the public reporting of utilization or procedure data on individual clinician profile pages. First, we are proposing to allow for more flexibility in procedure groupings and procedure categories so we can create clinically meaningful categories, particularly when one isn't available. We are also proposing to publicly report Medicare Advantage encounter data in addition to Medicare fee-for-service data to provide a more complete scope of clinician experience among the Medicare patient population and to address low volume counts. Finally, we are proposing to provide a single downloadable data set on the provider data catalog or PDC that is aligned with the procedure data we are reporting on the clinician profile pages instead of what's available already in the Medicare public use file or PUF. Next slide, please. Finally, CMS is signaling its intent to publicly report cost measures. We have developed an RFI seeking comment on potential approaches to publicly report cost measures, starting with the 2024 performance period, such as episodic or component level cost information for the episode-based cost measures. This also includes information needed to ensure that cost information is easily understood by users via benchmarking and or use of comparators, and also on the timeline for publicly reporting this information. We are also soliciting suggestions on other considerations for incorporating cost measures into public reporting. This concludes the public reporting proposal section, and I will now turn it over to Ketchum.
Thanks so much, Julie. Okay, so we're going to just quickly go through some reminders and then briefly talk about the resources available for both understanding and then commenting on the proposed rule. Next slide, please. Okay, so some reminders. The proposed rule will be published in the Federal Registrar on August 7th, 2023. And CMS must receive comments within the 60-day comment period, which will close on September 11th, 2023. And comments can be officially submitted in one of three ways. Those are electronically, by submitting them through regular mail to P.O. Box 8016, Baltimore, Maryland, 21244, or by submitting them through express or overnight mail to mail stop C4-26-05 at 7500 Security Boulevard, Baltimore, Maryland, 21244. And regardless of the method you use to submit comments, file code CMS-1784-P should be used. And CMS must protect the rulemaking process and comply with the Administrative Procedure Act. And finally, while participants are invited to share initial comments or questions, Only comments formally submitted through the process outlined in the Federal Register are taken in consideration by CMS. All right, next slide, please. Okay, now some resources. So the proposed rule fact sheet and policy comparison table, the proposed and modified MVPs guide, and the proposed rule Medicare Shared Savings Program proposals fact sheet are all available on the QPP resource library, and links to all those resources have been added to the chat in Zoom. So please do be sure to take a look at those as well. We recommend these resources as well as the proposed rule itself for more information about what the proposed rule includes. And for practice or facility specific questions, please contact the QPP Service Center, which is available Monday through Friday from 8 a.m. to 8 p.m. Eastern and can be contacted by email at qpp@cms.hhs.gov, by phone at 1-866-288-8292, or by opening a QPP Service Center ticket. And to help ACOs navigate questions regarding the Shared Savings Program, we do recommend they contact their ACO coordinator as their first line of contact. And finally, people who are deaf or hard of hearing can dial 711 to be connected to a TRS communications assistant. Okay, next slide, please. Okay, so now we're going to jump into the Q&A portion. But before we do, I do again just want to remind everyone that the recording of today's webinar, as well as a copy of the slides, which will include all the hyperlinks you saw on screen today, is going to be available on the QPP webinar library in the coming weeks. Okay, back to the Q&A. If you have questions, you can ask them through either the Q&A box, as many of you have already been doing, or through the webinar audio. And to ask questions through the webinar audio, please do raise your hand and we'll unmute your line so that you can speak. And you may also need to unmute yourself as well, but we'll prompt you to do that if it seems like you're double muted on your end. Now I will turn it over to my colleague, Lindsay, who will begin taking your questions. Lindsay.
Thanks, Matt. Thanks, everyone. We'll just kick it off with a few of the questions that came in during the presentation, and then we can go to the phone lines. So the first question is, are there any preliminary thoughts on how multi-specialty clinics will be treated if when MVPs become mandatory? We have 11 different specialties, and potentially requiring each specialty to report an MVP will increase our quality measures from 6 with traditional MIPS to 44 as MVPs, and our improvement activities from 2 to 4 with traditional MIPS to 22 to 44 as MVPs. That will significantly increase the reporting burden for our providers.
Yeah, sure. Thanks, Lindsay. So for this question, I just want to be clear for multi-specialty groups or practices that are reporting MVPs. You have until 2026 to continue to either report as a multi-specialty group, or if you choose to, if you opt to adopt subgroup reporting earlier, that would be obviously encouraged. I just want to be clear when it comes to subgroup formation, we have not set specific stringent criteria that limits the number of clinicians within the subgroup or the number of specialties within or subspecialties within a subgroup. We did that intentionally because obviously, medicine is not black and white, and, there are various practices may practice in different ways. And to respect that, we've left subgroup formation, the criteria around it, a bit broad. So it is our intention to, allow for subgroups to form in a manner that is the most meaningful to their practice. And that might mean at the most between your 11 specialties within your multi-specialty practice that you form 2 subgroups. We really defer to you as the practice to look to see the availability of MVPs, and then to your discretion form subgroups that would really resonate with your clinician's practice, so they can actually receive data based off their performance on an MVP reporting that really resonates with them. So I want to be clear that the criteria is not stringent. So there is the opportunity to give that discretion to the practice to then determine how many subgroups they will form and then report through. We do acknowledge there is burden with subgroup reporting, but the value of it is in our perspective high, in that you can have more granular data that is received from these clinician groups, rather than a multi-specialty group reporting only, for example, primary care measures that are not necessarily attributable or meaningful to the other specialists in the group, that they can actually report on measures that mean something to them and really engage in the program. And on the other side of that, patients can also make use of that data that is a result of reporting, and make more informed decisions of the care they receive. So I hope that helps, but there's additional resources on our resource library related to subgroup formation, and I hope you find that helpful.
Great. Thank you, Sophia. All right, for the next question, how are the most clinically relevant measures and activities that are included in MVPs decided upon? Who participates in the conversations? And this might be one for Sophia as well.
Sure. So there's two processes that we have in place, one related to MVP development and another separate process that's related to MVP maintenance. So for MVP development, we allow for our external entities and stakeholders to submit MVP candidate submissions to us. We have also taken the precedence to also proactively work on some of our own as well, to the extent we can. In those instances, we've tried to work with a few cohorts of external entities to then get their input on new MVP creation. And we've previously finalized in last year's rule a process in which for new MVPs, before they are actually proposed, we would publish them for a 30-day comment period. So the MVPs we proposed in this rulemaking cycle were previously posted this past January for public comment on our QPP resource library. And then on the other side of that, and now those same MVPs, the new ones, are being available for public comment through this rulemaking comment period. For our MVP maintenance process, we accept feedback on our existing MVPs throughout the year. For stakeholders provide comments to us on what they believe should change, whether it be certain measures are missing or added, certain measures should be removed. Same thing with the improvement activities and or cost measures as well. And that feedback is taken into consideration. We hold a webinar annually to discuss some of the feedback received. And then you will see the results of the maintenance process and the feedback we received through the rulemaking cycle. And that really covers the process. Thank you.
Great. Thanks, Sophia. We're going to turn to folks who would like to ask their question live. If you have your hand raised, that's how you indicate to us that you'd like to ask a question. So hopefully the folks we call upon did not do that in error. So it looks like the first person in line is Polly Porter. So we're going to unmute your line, Polly, and you may need to unmute on your end as well. But Polly, would you like to ask a question? Polly, can you hear us? Okay. Does not sound like Polly would like to ask a question at this time, so we will move on to Stephanie Sousa. Stephanie Sousa, we're going to unmute your line. If you'd like to ask a question, please go ahead. And you may need to unmute on your end as well, Stephanie.
Hi, can you hear me?
We can.
Hi, I had just had a question just to clarify on the MVP voluntary reporting. If clinicians choose to voluntarily report, are they only expected to submit the data for MVPs, or do they also have to submit data along with traditional MIPS inventory, the traditional MIPS framework?
Sure. Hi, Stephanie, it's Sophia. For your question, yes, currently MVP reporting is voluntary. Clinicians have a choice between MVP reporting and traditional MIPS. You're not obligated to submit both. So if you choose to register and report for an MVP through an MVP, then you only have to submit the data required to satisfy MVP reporting. We do have clinicians also, just so you're aware, that choose to submit through traditional MIPS too, because we do have a scoring hierarchy that we previously finalized that allows clinicians to submit a MVP submission and also separately a traditional MIPS submission, and we will score both score both submissions separately, but then take the higher of to count as the clinician's final score. So since we have that flexibility in place, we've heard from stakeholders and clinicians that they are, especially in the first year of MVP reporting, interested in doing that just to see how they do on both sides of things before ultimately determining, that they want to move permanently over to the MVP space. But for the sake of reporting, you're not expected to do both. It's up to you as a clinician to decide.
Great, thank you.
No problem.
Great. Okay, we'll do one more phone question and then we can go back to some of the folks who have submitted questions through the Q&A box. So David Tedder, we are going to unmute your line. Hopefully you have a question ready, and please remember to unmute yourself as well. David? Okay, we will move on then to Molly Clay. Molly Clay, if you're interested in asking a question, can you please unmute your line? Okay. It does not look like Molly is ready to ask a question at this time, so we'll just go back to the chat quickly. So question from an attendee. For the MVPs, is reporting required on each QM and IA listed, or is it still a choice of 2 to 4 depending on impact level, as in traditional MIPS?
There is still some choice. So for example, for quality of the quality measures listed, and sometimes there are quality measures and QCDR measures in MVP, you only have to select and report on 4, one of which should be an outcome or a high priority measure. For the IA section of the MVP, you can select either 1 high weighted activity or 2 medium weighted activities. So you have some selection choice within the IA list as well. Costs, there is no selection. We just try to calculate those measures, and if we can, then we do so. Otherwise, we have cost reweighting policies that then reweight cost to quality if you cannot be calculated on the cost measures. And then I think, PI, the same requirements of PI and traditional MIPS carry over to the MVP space as well.
Great. Thank you, Sophia. So another question, this one is related to the promoting interoperability category. Maybe I missed this, but is there still a small practice automatic reweighting for PI for 2024?
Hi, this is Elizabeth Holland, and yes, there is still the automatic reweighting. We did establish that policy several years ago, and in order for that policy to go away, we would have to formally propose it in a proposed rule, and we have not done that. So that automatic reweighting for small practices, that's those practices with 15 or fewer clinicians, will stay in place. Hope that helps.
Thank you, Elizabeth. We will ask another question through the chat. In looking at public health registries that are considered bonus categories, there is no information regarding what registries are included. Example, no information regarding a quote declaration of readiness by the public health agency, nor is there information regarding the user of CERT or specified data standards. This may make determining what registries are in scope for meeting these measures.
So this is Elizabeth again. For the promoting interoperability performance category, you are correct. A bonus measure is reporting to a public health registry. So what we say is a public health registry is one that is sponsored by a governmental entity. So that could be a county or a state, something like that. So it needs to be governmental, first of all. And then on their website, they need to have declared readiness. So if there is a public health registry that you're thinking of, you would need to go to that particular registry's website and see if they have declared readiness. And if they have, then the first stage of active engagement is to register and get yourself into pre-production. And so we, unfortunately, the public health registries change frequently. And so CMS does not have the capacity to keep a repository of all the public health registries available. But if it fulfills those criteria, that it is ready and that it is sponsored by a governmental entity, those would fulfill what a public health registry would be considered. Hope that helps. Thank you. Bye.
Thanks, Elizabeth. Okay, next question. Can you please clarify subgroup reporting required by 2026? I thought MVP was not yet required.
Thanks, Lindsay. It's Sophia. Yes, that's correct. MVP reporting is not required by 2026. However, in previous rules, we've previously established as we finalize the subgroup policies that subgroup reporting would be mandatory for multi-specialty groups beginning with calendar year 2026 for those multi-specialty groups that are interested in continuing to report MVPs. Now, there will be a future state where, as we've flagged in the past, of us intentionally working to sunset traditional MIPS and in which only MVPs would be available. And when that happens, then all multi-specialty groups will be expected to form subgroups in order to report MVPs.
Okay, great. And then I think we have another MVP related question for you, Sophia. If you register for MIPS MVPs by the deadline, but then change your mind, can you just report traditional MIPS, or if you register for MIPS MVP, do you have to report that way?
Good question. You are not obligated to report even after you register. So if you register and then decide you want to just report traditional MIPS while it's still available, you don't have to do anything. You can continue to just submit your traditional MIPS submission during the data submission period. You will not be penalized for not submitting an MVP, even though you registered for it. So there's no issue with that.
Great. Okay, thank you, Sophia. I think we have time for one or two more questions, so we'll go back to the phone line. It looks like Jason Shropshire, I butchered that, I'm sure. Jason, we will unmute your line if you'd like to ask a question now.
Yes, can you hear me?
We sure can.
Great. Can you please clarify for Medicare CQMs, will we have to deduplicate at the patient level before we submit the data to CMS? For instance, if we have an APM that has 6 tax IDs, the patient is applicable in 3 of those tax IDs for the measure. Do we deduplicate and send only 1 instance, or would we send all 3 instances and CMS deduplicates?
Erin, would you address the question, or Sabrina?
Sure thing, I can jump in. This is Darren. So the intent is that operationally, this would mirror what an ACO would do when reporting a MIPS CQM, but the eligible population aligns with that definition or the proposed definition of a beneficiary eligible for Medicare CQM. We would refer ACOs back to the guidance which was posted in December on the QPP library about deduping and meeting data completeness criteria. We anticipate if finalized that those guidance would be updated to be inclusive of Medicare CQMs, but they would, the deduplication and patient matching would also be a component of the Medicare CQM reporting.
Okay, thanks.
Okay, I think we have time for one more question before we wrap up. So Jennifer Gasparini, you have your hand raised. If you would like to ask a question, we will now unmute your line.
Great, thank you. Jennifer Gasparini with the National Association of ACOs. I have another ACO specific question. When you're talking about Medicare CQMs and the patient population ACOs will need to report on, one of your slides had some conflicting language with what is found in the rule. So I just want clarification. Is it the patients that meet the criteria for a beneficiary to be assigned to an ACO and meet the specialty requirements in assignment? Or is it something else, something like what you had listed on your slide in the presentation today?
I think some of the slides try to simplify the language in the proposed rule, but I'll answer that. The intent is that the population, the beneficiary does not need to be assigned to the ACO to meet the proposed definition of a beneficiary eligible for Medicare CQM. If you look at the specific reference in the proposed reg text, it's referring to the step before assignment. And so the criteria would be that they meet the eligibility for assignment and they had a claims encounter with a provider with a specialty used in assignment or a primary care physician or a PA or CNS or nurse practitioner, or they voluntarily assigned to the ACO. So that would be the step, the aggregation of data that should occur before the ACO then applies that population to the measure specification.
Okay, so they do have to meet the criteria to be eligible for assignment and have the specialty designations in step 2 of the assignment.
Yes, but they do not need to be assigned.
Correct. Okay, thank you for the clarification.
Great. Well, we are just about at time, so we are going to turn it over to CMS to finish out the webinar.
Great, thank you, Lindsay, and thank you everyone for joining us today. We appreciate all the very good questions we received, and we look forward to the public comments you may have. As the previous slides have indicated, our public comment period for the rule closes on September 11th, so please make sure to follow the formal process to submit your formal comments for our consideration. And please make sure you can make use of our resources for the NPRM and our QPP resource library, and also our service center at your disposal. Thank you very much, everyone. Have a great day.